A very good evening to everyone and a very warm welcome to all our delegates and faculty members to No Thrombosis. I'm very, from behalf of MCure, I'm very delighted to, inform everyone that, in No Thrombosis program has got, most engaging scientific platform from any pharma company award from the SIEMS Medica. So this has happened because with all your support and all the delegates, so consistently we can see that, more than every time, more than 600 registrations, it will be there for the programs. And that has really made a lot of difference specifically for the no thrombos. And with also the support of Hiremot sir, consistently, this is our almost 38th program we are running today, and with completely the single-handed support from Hiremot sir. And thank you, sir. Thank you so much for your support for this program. And, so Shri Hiremot sir is our course director for the program. Sir is director and director at Cath Lab Ruby Hall, Pune. Sir is president of CSI in 2017. Sir is also a convener and National International Interventional Council of India, CSI 2004 and 2006. And sir was promoted many interventional cardiologists and has given live courses across the globe. And through coronary intervention is as at heart at equally at peripheral arteries interventional like leg, carotid, and aorta, and as well as participated in some ground breakthrough trials also. Sir is well known the renowned cardiologist in India, and from behalf of MCure we want to welcome to Graham sir. Welcome, sir.
Thank you.
And I'm very glad to introduce our today's moderator, Dr. Girish B. Navsundani sir. So Dr. Girish Navsundani sir, he is from Bangalore, renowned cardiologist. And he from consistently is associated with our no thrombosis program. And sir is the director Cath Lab in Syrian interventional cardiologist from Apollo Hospital, Bangalore. He has extensive experience of several years in the field of cardiology. Dr. Navsundi sir has performed over 1,700 angiograms through femoral and radial and ulnar approach. Dr. Girish Navsundani sir has presented numerous research papers and has written for several journals. So from behalf of MCure, I welcome you, Girish sir, for the program today.
Thank you. I think we need to change this slide next time.
Yeah, sure, sir. And next is our speaker. Speaker is our Dr. Samir Kuba, sir. He's our speaker for the program. Dr. Samir Kuba is a director in clinical and interventional cardiology from Max Hospital, Vaishali from Delhi. He has extensive experience of more than 16 years in the field of cardiology. Dr. Samir Kuba has participated in many national and international conferences as faculty, also published many articles in national and international journals. So Dr. Samir sir is today with us, and he is going to present a very good interventional case. And the next speaker is Dr. Sama Akbar. He is an interventional cardiologist from Medway Heart Institute from Chennai. He is visiting consultant to various hospitals in Chennai, and he is a member of one of prestigious, Pediatric Cardiac Society of India and Cardiology Society of India. So from behalf of MCure, I welcome to all our speakers today. So as per agenda, the first case will be today is presented by Dr. Sama Akbar. He is going to present on, double trouble in primary PCI. And followed by, we'll have a special case presentation by, Hiremot sir. And then third case will be, Dr. Samir Kuba. So he will be presenting on, LMCA, PCI in ACS, 2 cases in managed with a simplified approach. So once again, from behalf of MCure, I welcome to all our faculty and delegates today for today's 38th program of No Thrombosis Live in Box program. And with this, I will hand over the sessions to Dr. Shirish Hiremot sir. Thank you.
Thank you. I'm in California, so I don't know whether to say good morning or good evening, but let's say good evening because majority of you are linked in India. So we start with Dr. Samir Kuba's case. Dr. Samir, over to you.
Good evening, sir. I'm Dr. Sama Akbar. I've been scheduled to present first.
Oh, no, sorry. So Sama, you can start.
Pleasure, sir. So double trouble in primary PCI. So my history begins with a 60-year-old male presented to our ER in an unconscious state. He had complaints of chest pain since 2 hours with 1 episode of syncope. On arrival, the patient's BP was 60 query. The pulses were feeble. The GCS was E3, V4, M5. The ECG revealed ST segment elevation in V1 to V6 and leads 2 and 3. This is the ECG which we saw. It had significant ST segment elevations in V1 to V6, and also some ST elevations in leads 2, 3, and AVF. There was minimal ST elevation in 2 and 3, but the predominant ST elevation was there from V1 to V2. 1 second. Sorry for the interruption. Yeah, so get back to the case. So the patient was treated with initial loading dose with aspirin, ticagrelor, and atorvastatin. He was started on noradrenaline infusion of 0.2 microgram per kg per minute. He soon developed vomiting and ventricular fibrillation on the monitor. He was given a DC shock at 200 joules 4 times, and CPR was given for 1 cycle, and then he was resuscitated. Emergency intubation was done, and he was connected to a mechanical ventilator on volume control mode. The ECG showed a complete heart block, and it was surprising a STEMI with inferior MI. He is a known case of diabetes mellitus, systemic hypertension, coronary artery disease, and COPD. He's a known smoker with a history of 20 years of smoking, occasional alcohol intake. He also had a history of primary coronary intervention in 2011 for an angio MI. He's not on, and he was not on regular medications. Yeah, and he has no other comorbidities. On investigation, we also got a preliminary lab report. Significantly, his potassium was 0.6, which was the only abnormality. Otherwise, a total count of 19,900. We attributed that to the MI, and a creatinine of 1.5 was there. The echo showed severe LV systolic dysfunction with an EF of 29%, mild RV systolic dysfunction, a TAPSE of 10, with suspected RV MI as well. All valves are structurally normal. The IAS and IVS were intact. Grade 1 diastolic dysfunction was there, and grade 2 MR were there. No other mechanical complications of MI were noted. So we proceeded with this background. We proceeded to the coronary angiogram. When we took him into the cath lab, we went by a femoral route. And since he had also developed inferior MI with a complete heart block, we placed a temporal lead in the RV. We can see the temporal lead, and we can see that the left coronary artery, left main coronary artery, followed by left anterior descending, had a thrombus in the proximal region. Then even the right coronary artery had a thrombus in its proximal region, and he was in complete heart block. Seeing that he was in complete heart block, we didn't waste any time. We went ahead and we decided that we will go ahead and stent this right coronary artery. Initial daughtering was done with a non-compliant balloon. We didn't waste much time, and we went with a direct stenting approach. There was a good waste over there, if you can observe. And then after the initial stenting, we didn't have to do any post-dilatation. We didn't waste any time. And we had good revascularization of the right coronary artery. It was a big vessel. It opened up quite nicely. There's some disease in the distal segment, but we didn't address that immediately. The moment we stented the right coronary artery, the patient went into severe hypotension. He had developed VT. We had to shock him. So he was not recovering even though inotropes were being increased. So we decided that we will also attempt to revascularize the left territory. We initially put a balloon and we opened up the proximal segment of the left. We opened up the proximal segment of the left anterior descending artery. After the initial pre-dilatation, we also placed a stent in the proximal left coronary artery. So the proximal LAD was also stented. As you can see, the silhouette of the heart showing VT going on. we had to shock him multiple times, close to 18 times we had to shock him. And you can see that there are multiple burn marks because of the shocks we had to deliver. He developed a VT storm, multiple shocks were delivered, but the patient was subsequently treated also for hypokalemia, side by side. NORAD infusion along with amiodarone and xylocaine was continued for the next 12 hours. He developed no further episodes of the initial VT storm. After that, he had no further episodes. He was extubated and all inotropes were tapered off. His ECG settled well with good ST segment resolution. So I'd like to discuss this. So acute myocardial infarction involving 2 or more culprit lesions at the same time, known as double or combined infarction, is a rare event with a poor prognosis. Most cases involve the right coronary artery and the LAD. The autopsy studies show that 50% of the patients 50% of these patients actually have multiple culprit vessels. But by contrast, Pollack et al. Found that only 18 cases of his study of 711 patients undergoing primary PCI had multiple culprit arteries. So that is only 2.5%. So why would we have this? It's basically a selection bias in that patients with multiple culprit arteries are more likely to suffer sudden cardiac death, not surviving long enough to undergo a coronary angiography. 1/3 of these patients presented in cardiogenic shock, and 1/4 had potentially fatal arrhythmias or required intra-aortic balloon pump. So what do the guidelines say? So based on the Stemi Guidelines, primary PCI of the IRA is indicated as class 1A. And in fact, the non-IRA strategy, it says that routine revascularization of non-IRA lesions should be considered in STEMI patients with multi-vessel disease before hospital discharge. So yeah, 2A for that. And a non-IRA PCI during the index procedure should be considered in patients with cardiogenic shock. So basically our case in question had a class 2A level of evidence C. So we did get a good result thanks to this approach. And also I'd like to bring in the complete trial in 2019. The complete trial showed that amongst patients with STEMI with multi-vessel coronary artery disease, strategy of staged non-culprit lesion PCI with the goal of complete revascularization resulted in a 26% lower risk of composite or of death from cardiovascular causes or new myocardial infarction and mean follow-up of 3 years than did a strategy of culprit lesion only PCI. The benefit of complete revascularization was consistently observed regardless whether the non-culprit lesion PCI was to be performed during the index hospitalization event or several weeks after discharge from the event. So even if we did it during the index event, in our case, or many people did it as a staged procedure within 45 days from the index event, but there was the benefit of complete revascularization was consistent. So this was the first, the primary and secondary outcomes to the study, to the complete study. Culprit lesion only PCI demonstrated a higher cumulative evidence of bad outcomes, such as a death and CAD, or death due to CAD, or because of or a new MI, as compared to the complete revascularization, even across the years of follow-up. So the long-term outcomes were much better. And amongst the 4,041 patients, the secondary outcomes, that is, it included also ischemia-directed revascularization. It had a far better outcome in the complete revascularization group. So contributing now, also, what are the contributing factors for a double myocardial infarction? So heightened inflammatory response and catecholamine surge caused by the acute occlusion of one vessel, leading to a secondary coronary artery occlusion. Hemodynamic instability and hypotension due to occlusion of one coronary artery, resulting in blood stasis and acute occlusion of another artery with severe underlying lesion. Current tobacco use. In fact, Pollack et al. Study had about 56 patients who were 56% of the individuals who had double MI were current tobacco users, and prolonged coronary vasospasm due to Prinzmetal angina or cocaine use, hypercoagulable states including malignancy, hyperhomocystinemia, thrombocytosis, and coronary embolism. So these are all contributing factors for a double MI. And the patient in question, he developed well. He's been on follow-up at government general hospital currently. It's been more than 3 months. He has not had any rehospitalization, even due to heart failure or due to angina. So that's what I wanted to present with regards to our fascinating case.
In the current situation, you should also add COVID there, because
Yes, sir.
COVID can produce thrombosis in multiple sites, and you will probably get multiple infarcts at different locations.
Yes, sir.
In 2022, this slide would probably disappear. Anyway, great presentation. Why did you go for RCA first? I mean, the ECG showed huge ST elevations in the anterior leads.
Yes, sir. The initial ECG, ECG did show only antro-LMI, but after the event of VT, we shocked him and it showed ST segment elevations in 2, 3 and AVF on the monitor. So we didn't waste any time and we immediately went for an angiogram. He also had complete heart block.
Let's ask Dr. Girish. You are seeing ST elevation in anterior leads, and a little later, say 5 minutes later, you are seeing inferior leads, and you have an occluded LAD and occluded RCA. Which one will you go for?
So you're muted, sir.
You're muted, Dr. Girish.
I always go by what is my at presentation diagnosis, which is an antro-wall MI. At the time of that shock, he could have developed a thrombosis in RCA just before, defibrillation. But either ways, when the vessel which is dominant, opening that on a priority always gives you hemodynamic stability. And it's always the left anterior descending artery, which is the most, contributing channel for the myocardium of the left ventricle. So probably I would have tried the left first with a wire in the circumflex. That's my suggestion, because, in a thrombotic lesion, sometimes the clot can migrate to circ. I know you're in a cardiogenic shock, but always, try a small wire in the circumflex. It gives you a great deal of safety. But I've gone with LAD first.
Yeah. Dr. Sama, even I would feel a patient of cardiogenic shock. I think go for LAD first. That was the discussion.
Yes,
LAD showed a huge ST elevation, so I would also go for LAD first.
Sir, also, he had a past history of an antro-wall MI in 2011, for which apparently a balloon angioplasty was done. Could it be that territory was already non-viable, or it was maybe less viable than the RCA?
What did the echo suggest?
Initial had global hypokinesia. It had severe antro and inferior.
No, but could you see a thinned out, infected LAD territory?
No, sir, I don't think that was the picture.
I think in that case, I would still go for LAD first. I think we spent enough time which one to do first. And this is many times division. We have 3 cath labs and there are about 10, 11 cardiologists at one given time in the cath lab. So when such a question comes, everybody is giving his opinion, and probably 5 on this side and 5 on the other side. So whatever you did, your patient is alive and doing well. So you have confidence and reason to say that whatever you did was very correct. Then when you did the right coronary as well as LAD, it was obviously a thrombotic lesion, critical lesion, or semi-critical lesion. And you did a direct stenting in the RCA. Do you use some intracoronary GP blockers or lytics at that time?
No, sir, we didn't use intracoronary GP2B3A inhibitors.
I would definitely feel that. I'm not sure whether I have evidence from the science, but we found intracoronary usage of these drugs is, the clots are going to move downstream. So either you use a distal protection device, which is probably a little difficult with these kind of hypotension, double infarct situation. But I'm sure distal protection device and intracoronary usage would probably preserve. See, once they go distally, you would always struggle to get the myocardial function back. But if you are given GP blockers intracoronary, I think it would help us.
Yes, sir.
And I should really congratulate you, Sama. It was fantastic. The speed and agility with which you made your decisions, and finally he's walking around. But a couple of suggestions. I would always put an intra-aortic balloon pump once I see a high-risk subset, because hemodynamics is more important than just establishing the blood flow. Just starting the coronary flow will not solve your problem. The VT was more probably ischemia-driven than anything else. The LV wall stress would be tremendous. So putting in an intra-aortic balloon pump or an ECMO would really give you ample time, especially in someone who's got a VT store. So next time around, if you're faced with a
Dr. Girish, at this stage, I would also suggest we should train. Another cardiologist help may or may not be available immediately. So we should train our senior nurse to get a puncture in and pump in. It doesn't take too much wisdom to do that. So as you're working on the coronary, I would feel the nurse could get in. Okay, back to you, Dr. Girish.
Build your team. If you're going to manage a lot of acute coronary syndromes, these are like storm. You need to work as a team, as Dr. Sir says, have people contributing in different dimensions. You could be a leader, ring leader at that point of time, but they should be able to complement you with some critical assistance, on the ventilatory side, or putting in a defib patch, or putting in an intra-aortic balloon pump. I think
even picking up VF in the first second itself, it's a huge help. I've seen sometimes the VF has set in and then people are running around. It probably wastes about 2 minutes to get the first shock in. So all these different areas, I think emergency, different people should be trained to sort of hold the core area where they specialize. It doesn't need myself or Girish to pick up a VF. So I think VF shock quickly also is a great help for your case, Dr. Sam.
Yes, sir.
Thank you. Thank you, sir.
Thank you,
we
sir.
move on to my case now?
Yes, sir. Yes, sir.
All right, I'm going to show you something which happened very strangely. There was this man who had an angioplasty with us about 5 years back, and he was coming to the outpatient evening OPD, which is not in the hospital, but it is far away. And his wife, for reasons, she said, I want an ECG. So my clinical asked her why she wants an ECG, but she didn't say anything. She said, no, I'm good. I'm cooking. I'm doing everything as I want. But she wanted an ECG, which showed some ST changes. So we then asked her, do you want a stress test? And she said, yes. And then on treadmill, within half a minute, she started getting chest pain. More importantly, very good ST depressions. And at the end, less than 1 minute, we had to stop the stress test. And mind you, this patient had not come for herself. She had come because her husband always comes for follow-up. And she says, so she diagnosed herself to be a coronary patient. Stress test positive inside 1 minute with huge ST depressions and prolonged chest pain. We were all sweating because the patient probably had 50 patients waiting, and this patient was complaining of intense pain. So we convinced her to get admitted that night, and the next morning This is the angiogram. So I haven't shown you the left angio just now, but left angio also showed multivessel disease. And this is the right angiogram, which is a dominant vessel. So since left was very complex, we thought we will at least stabilize the right supply by doing the RCA, which looked like a simple lesion. But mind you, we had to really sweat it out. The conventional wires were very difficult to pass through this lesion, and we had to switch to Fielder XT. Now, this I do it many times because once it crosses the lesion, the movement of Fielder XT subsequently is very quick and fairly in the desired vessel. So once that was done, a balloon dilatation and then stent placement with post-dilatation. And this is the kind of RCA that we are seeing. Heavily blocked artery within first minutes. We have it flowing well. You know, this kind of thinking, I will show you the left system, but this kind of thinking, easy one first, I always thought, because it's a huge, dominant vessel, and it would improve the heart supply by at least about 30-35%, just one vessel, quickly done. So once this was stabilized, we thought we will go for the left. What we are seeing here is a very long left main. Always a bad news when we are doing a complex case, having this is almost 60 millimeter long length left main. You can see a critical disease at the circumflex mouth, a very late filling of the circumflex circulation. And in the next view, you would see a lesion, which is the LAD and branch like ramus or high diagonal. So all these are big branches. They are side branches. They have critical lesion. And on the top, you can see the circumflex showing the most critical lesion at this particular point. So probably the pain or the intensity of angina was from this lesion, which was something 99%. Other lesions were also important when you think of the position. So you have some lesion in the mid-LAD, a critical lesion in the circumflex, which is coming on the top because of this angle. Then this vessel, which is going towards OM. And then this is a vessel which is coming between circumflex and LAD. They're called it ramus or a high diagonal, which is showing an important lesion. And some disease at the distality of left main, critical, I would feel needs assessment. So if you're dealing with this kind of side branch importantly, I guess this has to have clarity as to whether that lesion is going to be important. So we thought we will start with the circumflex first, and the conventional wires were most of the time going straight to the OM. And that's why we had to switch to Fielder XT. And Fielder XT was first placed in the OM. Then we got the microcatheter. This is, I think, Guidezilla. And once the Guidezilla is at the opening of the vessel going up, we can bring the wire back, make an acute bend to the tip. So you can see circumflex has the wire in first. Then you bring in the Guidezilla to a correct location, reshape, and then you can advance this wire to the circumflex, which was very difficult. We chose this angle, I mean, quite a strange angle when you're dealing with circumflex and its branches, but we wanted to keep contrast to minimum because she had creatinine, which was 0.8, and She had standing diabetes. So finally, we have a wire in circumflex. So this was our stent was first placed in mid LAD. It was a simple lesion, mid LAD. Then the wire is now in the circumflex, and another wire is in the OM. So we are now trying to deal with this bifurcation, the circumflex and OM1. So at this stage, we put a wire in the LAD, which I feel safe to have a wire in LAD and vessel, which is so important. And we had withdrawn it after putting a stent, only because the lesions, the balloons were not going easily. So we have now 3 wires. We decide to do the mid LAD first. You can see here. Good idea to always avoid stent overlapping the multiple junctions. So the stent started a few millimeters away from the location at the distance. I always do this, bring the same balloon back, stent back, and go high on pressure so that the stent is expanded. Of course, we'll do INC dilatation later. But this going high pressure without having a risk of distal dissection, to me, I do very often, and I feel it's a very important step to do. So the mid LAD now has a stent, as you can see here, and the 2 wires are, top wire is in the circumflex, so we go for circumflex. So we go with the NC balloon. I always like to use NC balloon under these settings. Small diameter balloon, you can go high pressure, don't dissect, and you are in a good position to take a stent in. When we were trying to do that, the LAD wire was actually not allowing balloons to go in. So we had to withdraw the LAD wire. So when you're withdrawing a stented wire back, you have to be very sure that distal end is dissected. And after making multiple contrast injection, we took this decision to withdraw the LAD wire. So now we have a microcatheter towards LCX and on a balloon support, the microcatheter was brought in. You can see the microcatheter is sort of looking towards the circumflex, dilatation to circumflex, and the stent is now positioned here. So when you're trying to do that, I generally like to be ready with another balloon or a stent in the main vessel. In this case, it's circumflex atrium going towards one. This vessel is probably supplying a lot more myocardium back to the circumflex. So I thought we should have a stent in this position. However, the stent to the OM1 was difficult, and we had to sort of abandon that effort, and we placed a balloon on the OM1 water. So you have a stent towards circumflex, a balloon on the OM1. You deploy the stent. Actually, this stent is not going further. That's why we have to do these steps. Otherwise, we generally keep a stent in position and deploy the side branch stent. So once we pull that stent back, easy to open the balloon of the stent towards circumflex. So you have no balloon on this wire, which is not very good. Not go next on this wire easily. all the same, you can see when we have injected contrast with the inflated, you are able to see grooves in the OM, which clearly indicated that our stent is well inside the circumflex vessel floating in the OM. So once that was done, the LCX wire was withdrawn. See, we are keeping all the case towards the end because we wanted to be quick. This was a very high risk kind of situation. So the circumflex wire is withdrawn. We have only one wire in the OM. And now it's very easy for this stent to track in. So the stent is easily placed in the posture of the circumflex going towards the OM. We have a wire in the LAD, and this stent is now open. Bring the balloon, same balloon back, high on pressure so you don't dissect this, and you are giving good stretch to the stent. And this is in case if you miss out on NC adaptation towards the end. I'm not saying it's a must, but I generally like to do it in case if you miss out on NC adaptation, you're given a high pressure adaptation to the stent. Then we concentrate. So you can see the two stents going from going towards circumflex, second one, mouth of the circumflex towards the one. And now we have higher and in the high diagonal. We can call it anything. You can call it remus, you can call it something else. But I'm just going to call it. So the bed was prepared and the stent was put in place. And we are sort of adjusting the position of these two stents. I generally like to keep a stent in the main branch when you're deploying a side branch stent, because sometimes if the stent protrudes backwards, bringing in the next stent takes a lot of time, sometimes so on. So these two stents are probably now in position, and we are ready to go on the this diagonal stent is deployed. Deployment pressure could be 6, 8, nominal. We draw the a little bit back, maybe 2-3 millimeters, high on pressure, so that the stent is fully stretched. You can see with the contrast showing good expansion of the stents. The left main LED stent, which is now touching the deployed LED stent, is to be deployed. And we have all stents placed in the side branch. Now we chose this strategy, side branch stent first and main branch later, primarily because all the side branches are extremely important. If we put a main branch stent and if we struggle or take time to address the side branch, we would produce a tremendous amount of ischemia, leading to clinical instability. So whenever side branches are important and difficult to access, my strategy is to put side branch stent first and follow something like a mini crush, so that you always have stents in the side branch. And then we deploy the main branch stent. This is the 5 stents in position. So first stent was towards circumflex, second was towards the heart. The third one was in diagonal, and the fourth was left main to the LAT, entering the already deployed middle stent. So this is the time to do pot. Now pot is very important. So this is our first pot, and we are going to do a final pot in the end. Now this position of the first pot, the marker, has to be very carefully planned. It should not go across the mouth side. And this is more important when you do final. At this stage, the balloon must come and sort of be at the spot where the side branch stent is originating. This is how you expand the main branch stent well, and then there is a constriction, and then the side branch stent, and then it's easier to slip in. So you can see the stent which is already deployed is being stretched further with an NC balloon. You can see here at the end of that we are wiring the high diagonal, and we put a balloon to open up the struts towards the high diagonal. You can see a case between LAD and high diagonal at this particular stage. Once we do that, bring in a bigger balloon towards diagonal and do regular case. At this stage, we decided we would not do a kiss between circumflex and OM1. And we will do only a kiss between OM1 and the LAD left main. So this is what we are doing here, OM1. You can see the stent boost is showing a very good expansion and a good contact between metal and metal on this side. So we have 5 stents deployed in this side, in this left side, and then this final part or report is again very important. You can see the distal marker of the balloon should not hit the side branch first and towards second. So you keep it back. Even if you miss about 2 millimeters, I would still feel it is okay. I think for years and years we used to not do these steps. So giving up a millimeter is an issue. And this is what is our final result. You can see 2 stents, one in mid LAD and one in the LAD stent. Then we have deployed the circumflex stent next, then the OM1 stent here, and then the diagonal stent here. So all vessels had a final kiss. There was a lot of stability when we achieved this. I mean, we had stents in place, blood flowing fully well. So we decided we'll rewire the diagonal and do a kiss between LAD and diagonal, between circumflex and LF. This is final result. So this case, with a very strong positive test, we did a simple RCA lesion first. Again, big circulation was stabilized. This helped us to stabilize very effectively when we were going for left-side stent. The mid-LAD stent was probably the simplest. The first one here. Then the second one went to the circumflex because it had 2 bends to go through. And the third one, circumflex mount, the OM1. So these are all mini crush here. Then we put a stent towards diagonal, ramus, whatever. And then stent in the left main to LAD. So we chose mini crush technique by design because we wanted to have in the side branches very positive. All were very important side branches, and we had wasted time on the main branch stent trying to wire the side branch. I think so. This is a few months old story. Somebody who walked in with a very strong positive test. We ended 5 stents in the left. You can see the sequence. Let's stent first, so you get a 50% supply established, reasonable stability. Then mid-LED stent, again a very simple location. And then you go for bands like circumflex stent next. That's one stent next, a diagonal stent next, and so once all stents were placed, we did a kiss between diagonal and LED. Then we did a kiss between circumflex and we missed. I mean, I thought this kiss between circumflex and OM was probably very difficult. Getting wire in, struggling to get a bone in. We have increased the procedure time and contrast to only about 40 to 43 kilos and a standing diabetes with high creatinine. So we thought this was a good sort of stage to end in, where we have effectively produced this. We missed our case between circumflex and OM1. This, I think, is acceptable because over time the surgeon doesn't even graft the circumflex, right? Because it runs through the AV surface. I mean, it doesn't support much of the vessel. This is probably the least important vessel, and we therefore missed out on fire. Not that we didn't want to, it's just that it's too complex to get a wire through up. And the choice of this angle was very important. So the first angiogram was studied again and again. We made a sort of conscious effort to try and do the entire procedure in this particular. If you keep changing angle every time you have contrast, and in this lady who is diabetic for long duration and have a raised creatinine, very difficult. So patient very stable, went home after 48 hours, creatinine change and the usual option. So she would be on that. So I will stop here. Questions? Take questions. Dr. Girish.
I think it's so fabulous. I'm seeing it for the second time, so I thoroughly enjoyed, the thought process behind how you strategized so many stents and more importantly, when you chose a mini crush, when you chose a provisional stenting. I think approaching a multi-vessel disease is really an expert's, joy. I think what was more than the outcome, the thought process that has gone behind approaching each of the lesions, which wire you wanted to keep. We know some of those wires can cause perforations, but you have that agility to keep them secured at that location without migrating. And, you have to have strategies for 3 stents, recrossing. I think it's a beautiful mind's work. That's all I can say, sir. Excellent.
When you do the first perfect, one always thinks of doing a kiss then and there, which I think takes a lot of. And then the rest is struggling with it.
Your voice is not very clear, sir.
No, we are, when we do a first bifurcation,
Right.
we want to do the kiss then and there.
Then and there, sure.
May or may not happen quickly. Sometimes it may take time. And if you take too much time, there could be an ongoing ischemia which might make the patient's condition.
Yeah. I think prioritizing the main vessel and whatever we wish to do to the side branches, looking at the area subtended by them, I think that's all time that needs to be devoted to them. If too much time is dealt on small areas to be preserved, I think we would be compromising on the largest territories. I think very well said. Try to simplify the bifurcation there. And even if the stent may not do as well, it's okay. But keeping everything going in that one attempt, keeping the timeline for each of the lesions, and very beautifully securing the major vessel, I think that should be the priority, isn't it?
Yeah, I would think what you say was actually crossing our mind too, that get the blood supply stable to all the vessels, and then you can give them finishing touches with the final case or with the complex. So I think stent establishing stabilize the patient and give you enough time to go in for the perfecting the result.
I think very inspiring. Since it's second time, I had to relive it, but it's a beautiful thought process, as I said, sir, and done very elegantly without having to get stuck with the wires or the balloons. Flow seemed very, very smooth. Thank you.
The choice of Fielder XT on the right was something which is not something which I do often, but we started with a conventional wire like Peppercoat, and we struggled to get the wire down. And we knew that if we take time on the RCA,
yes,
the left area would be very ischemic. So we didn't want any hypotension during RCA. That is why we took a Fielder XT. I mean, it's a little unusual choice, but I think it helped us to finish the RCA.
Very true. I think today, if there's any flow which has significant narrowing, I think first choice would be an XT, as long as you know to keep it in the true lumen. Earlier, people would use a whispered, but it's been completely replaced by XT. And it's a good, you're a good proponent of how to use these wires, although they call them CTO wires, but they're not always only for CTO, especially those critical situations where you need to negotiate a hydrophilic wire at the fastest pace. I think XT is number one there.
The only issue is the radio opacity, whole length.
Whole wire.
Is whole wire actually.
You can't do the balloon.
Yes, so we do a balloon and then you really struggle length to stent. So every time I'm putting a stent on XT, I probably end up with a slightly bigger stent.
Right.
That's the downside.
Oftentimes, right, sir. I mean, one, what I do in such situations, usually take a microcatheter along, use the XT to cross, drill the wire down, and then take it to a regular wire, and you can safely forget about where it's moving and things like that. Add on cost.
Also, this technique would avoid the wire tip perforation. Like XT, if you move forward with advancement of balloon, it can occasionally with the tip is the end of the vessel. So this is how changing wire over microcatheter is actually very useful.
Very nice.
So are there any other questions, comments on this case?
Dr. Samir Kuba, Dr. Samakbar, if you have any questions, you can ask. Dr. Samir, are you here, sir? Dr. Samir Kuba, sir?
Yeah, I can see him. Samir, you have anything to ask or comment on that work?
I was mesmerized by the whole discussion that was going on. I don't have any significant questions here. There was a great discussion and I think a lot of learning.
So I think what we are learning from this case is basically the stress test was so strongly positive that we had to plan angiogram with minimum contrast. We took only one picture of the left and switched to right, one picture of the right, and then went into angioplasty to right, and then angioplasty to left. So, I mean, things have to be thoughtfully planned and quickly implemented. Waste time if the wire is not going, just change it to one. That is how speed is very, very important in these kind of cases. So all of you must have realized we put the first stent in the right in probably 7-8 minutes, and probably spent time on the left side. 5 stents probably took us about 2.5 hours. And then doing a piece was necessary on the left side. Took us another 15 minutes. So 3 hours time we finished it.
That's some perseverance. 5 stents in one coronary system, and with so many bifurcation coming, recrossing. But that's a great. In hindsight, your experience would speak that how to limit the contrast is very, very crucial, because subconsciously people would be injecting at a throw of a hat that they would like to check how is it. I think it's very important to know that oftentimes we don't need to check and keep that contrast to the minimum, especially in an ACS situation.
I mean, this is probably one of the rarest time when I have put stents in the circumflex in a epicranial view. Normally we are in a spider view or an ariochordal view.
Yeah.
Circumflex as well as OM stent went in an epicranial view, which is probably the first time in my life. But yes, it was to save contrast as well as to get a good position.
Fantastic. Sir. Love the thought process.
Yeah, all right, so we go over to next case.
Yeah. Dr. Samir Kuba, sir. Yeah.
Yeah. So Samir is from Max Delhi.
Yes, sir. Yes.
So I'll be discussing very straightforward, simple left main cases in ACS. These were 2 of my cases wherein this was the first one, which was a 60-year-old male with a delayed anti-oval MI, and hemodynamics were pretty okay. The LV was significantly dysfunctional. As you can see, the EF was about 35%. And that was the angiogram, which showed a significant thrombus-laden stenosis in the proximal LAD. And it was a delayed presentation. So now there was something which was ectatic or probably a ulcerated plaque also very near to the ostium. And then there was a tight 99% stenosis of the proximal LAD, again with thrombus. The right was by and large okay. The distal part had some 70-75% stenosis mid-distal, but that was flowing well. So now the issue was the positioning of the stent, which was either leaving that osteoproximal part and stenting the most critical stenosis, or bringing the stent to the ostium and do a osteal stenting. So decided to do a osteal stenting because there was a significant probably an ulcerated plaque although it could be ectasia as well. Used absciximab in him because of the heavy thrombus and had a good effect of that. And then a drug-eluting stent was placed down from the ostium to the proximal LAD. This was a 3.528 Zions drug-eluting stent and was deployed. And that is the clear stent live image of the Siemens machine, which shows decent expansion. However, I decided to use a 3.5 NC balloon for post-dilatation, and this was an Oxford balloon. And as you can see, there's some sucking of the guide which happened during the manipulation. And then we thought probably everything is okay, but on the right panel, as you see, there is something which is in the shaft of the left main, which was not there previously. So was it something which needed to be taken care of left like that? Again, in the apicaudal viewer, I compared with the diagnostic images. So this was not something which was happy looking, and there was something which had happened. We did not have imaging at that point of time to diagnose what it was. So then I decided not to leave it as such, and decided to place in another stent from the left main to the LAD. This was a 418 drug-eluting Zions stent. And then a post-dilatation was done with a 4.5 millimeter balloon. And that was the final result with a TB3 flow, although there was some compromise to the distal vasculature, which did happen. So probably either there was a thrombus migration into the left main, or there was a guide-induced dissection. I don't know, because I didn't have imaging. But I decided to stent him at the left main ostium. He did well. I did not recross into the circumflex and did not do a dilatation of the circumflex. The ostium looked okay. And he's doing well now at almost 3-month follow-up. This is another case where during the COVID times, we had a tough time of a patient who came in the first COVID wave, a lady who was referred from another hospital with a delayed anti-AVOL MI, and she was not getting beds in any hospital. Mother of a doctor colleague, and she was very sick, diabetic with heart failure and delayed anti-MI. And the time was also 10 o'clock in the night. And as you could imagine, we were doing our primaries in PP during that time, and this patient was quite sick with desaturation and basilar crackles. Although she was conscious and oriented, and the hemodynamics are not very good, significant tachycardia of 120 and a BP borderline of 100 systolic. So that was the LAD, which was flush cut off from the ostium, and circumflex also had about 70% disease. There was some plaque in the distal left main, as you can see in the right panel. And there was a flush cut off of the ostium of the LAD. The right coronary was by and large okay. Now, I tried to wire this LAD, but it was very, very difficult. And the wire was persistently going into the small ramus, and the LAD was coming at a very acute angle. It was very difficult to wire with the routine wires and also whisper. And finally, a Fielder FC with 1.25 millimeter balloon support with a special curve would actually cross it. And this was the time when we were working with our mask and N95 and face shields and full PPE and sweating from inside with limited staff available. And then it was pre-dilated with a small balloon. Some flow started to come. The 2.5 millimeter balloon was used to dilate, and again the decision was to stent it from the left main to the LAD. And this was a 3.523 millimeter DES, which was placed from the left main to the LAD, keeping enough space of around 8 millimeters in the left main in case we require to do something with the bifurcation. And again, I kept the approach very simple and stented it. Post dilatation was done with a 4 mm balloon at 18 atmospheres. That was the final result. Again, in those conditions, crossing it into the circumflex and doing a ballooning, which ideally in all cases of bifurcation is recommended. But in both these cases, which I showed, I did not do that. And this patient is almost now 1.5 to 2 years, and she did well. We could manage her without any IABP or ventilator support. And recently did a CT angio for her, around 1.5 years of follow-up, and everything is fine. And patient is asymptomatic. Thank you very much.
Thank you, Dr. Samir. I think both the cases were very exciting. The second case, during acute setting, would you like to bring it back to left main, or you would start from the ostium? I mean, you had problem with the right also.
So there was a distal plaque in the left main to begin with in the areocranial view, and in that kind of a situation, to identify the true ostium and missing that ostium would have caused problems. So to me, bringing back into the left vein and stenting from the left vein to the LAD and doing a good post dilatation and ensuring a good apposition of the stent. And in case something happens to the circumflex, you can always rewire and do a kissing and all those things. But I believe if the ostium of the circumflex is not compromised and patient is relatively hemodynamically unstable, let us not do too much, and probably doing simplistic procedures like this can help. Bringing back into the left vein was important because in case you miss the ostium or there's something, then the procedure becomes even more complicated. You put in another stent and then there are 2 layers and then recrossing and other issues are there. So it was going on in my mind. I took a decision to stent it from the left vein.
No, actually, I would entirely agree that whenever you want to start the stent from LAD ostium, it's better to come back to left vein. Same probably does not hold true when you talk of LCX ostium, because the LCX circulation is probably not as important as LAD. So in a regular case, I would always bring it back to left vein. But here you're dealing with a recent infarct and probably a lot of thrombus. You use intracoronary GP blocker during this case?
No, I did not. The issue was that the lesion was very angulated and very fibrotic. And once a proper dilatation was done, the flow was pretty good. So, and she was an obese elderly lady. We were doing from the femoral approach, and I avoided GP2B. She was on ticagrelor and aspirin.
So, Dr. Girish, when you inflate a balloon to deploy the stent in a direct stenting, do you use some different technique if the compared to the chronic stable angina case?
I think it is a good case in the scenario of COVID times. If you really ask me, there are a couple of things that I would slightly do differently. First thing is, in an acute MI situation, the most important vessel is the one which is flowing, not the one which is occluded. But at no cost, there should be a compromise on flow in a flowing vessel. So kindly always put in a wire whenever you're doing not even ostium of the LAD, even the proximal part of the LAD. And if there is a probability of you positioning a stent close to the ostium or across, very important to have a circumflex wire, either for thrombus aspiration or taking additional tools. And secondly, whenever you wish to do the left main to LAD, be certain that the LAD is viable. If the ejection fraction is 25 and it's an infarct-related artery, we are going to go across a fully viable circumflex. And we are not certain that how much of that LAD would come back if you already have a large infarcted territory. But on the contrary, if you see a hyperacute MI, R waves preserved, the thickness of the LV is preserved on echocardiogram, then we are justified in taking a stent from left main to LAD across circumflex, which is fully functional and probably the vessel which is supporting the left ventricle. And secondly, I think oftentimes to bail out whatever you did could be the right strategy. But see, when you see a vessel like this, they are like V1 to V2, there is ST elevate hyperacute, and there is a small, significant part of the R waves are preserved. So I'm glad this patient ECG, if I only wish we had an ECG post revascularization in 2 or 3 days to know how much of that R wave is there and what happened to the echocardiogram.
Yeah, sir. So this patient is regularly following up with me, and now her LV is 45%. And she's doing very well. We did a CT angio repeat for her also. Right. And which shows the patent stent.
The whole idea, Dr. Sameer, is if we get the same patient again, how different are we going to do? I think what you have done is an object of discussion amongst all of us. If any one of us get to deal with this vessel again, in the clinical scenario that you are in, can anything different be done? So I just thought maybe I would protect the circumflex and I would probably go just from the ostium at that point of time and try and do. But if you're really in a unstable situation, because I saw that even when a pre-dilatation was done, can you please go back to the previous? There wasn't a wire across it. Yeah. My suggestion, one wire in the circumflex would be the great strategy.
Yeah, so sir, in that case, the issue was, it was an anti-MI clear cut and circumflex was a mid lesion. Crossing the LAD was very difficult. In fact, that was at such an angle. I tried the routine workhorse wire and, the steaming of the mask and everything. And so it was so difficult to cross the, so it was important to cross the LAD. So once I crossed the LAD, it was important for me just to take a small balloon dilatation. And I knew that I'm not going to actually occlude this circumflex, and the other wire was in place, and immediately the second wire was placed. And then obviously wire in place.
You did a fabulous job. No, just take things in a very prospective manner, not in the what has happened. Imagine if there is a clot and if it migrated to circumflex. That's all the fear is. I mean, whole idea is to make procedures safer and safer as we go forward. I think in a given situation, you've done a fabulous job. But if you're again doing it, probably there would be a circumflex wire. That's how I would look at it.
Absolutely, sir. I completely agree. I mean, in fact, the first thing to be done should have been to place a circumflex wire. Now, the issue was it was so difficult, just one staff with you. So the first wire which I took was a regular BMW and it just did not cross. And we were, even the whisper did not cross. And then the attempt at a fielder, and luckily with that angle and the balloon support fielder did cross. And then I did this, and I know retrospectively the first thing which should have been done was to wire the circumflex. But in that situation, sometimes and the wire wrap and all those things, and one stop with you, and middle of the night, a VIP family, all these things actually.
Fabulous. No, you have done a fabulous job. This is an academic discussion. But
the solution was at the, I mean, you see the very original images. You don't see the origin of LED at all. It was actually blind wiring of the LED.
Yes, sir. Actually, I just could not see. In fact, it was taking me time to understand what was actually the LED originating from, and the wire kept on going into the ramus. And that was the small ramus which was originating very nearby.
No,
And
that's why I'm saying that.
Yes, sir. Yes, sir.
Coming back to left main is more important in your case. I mean, if you had at least some vision of LDC, then maybe you can stop your stent vision of the LED. But since it was not seen at all, obviously, the vision or the clot was starting right at the vision of LED. And in these cases, I would always like to bring my stent left main. All right, any other comments?
Great, sir. If there are any, for discussion in the chat box, or anyone else has a comment to make?
Is there anything in the chat box, Ravi?
Yeah, no, sir. There is no comments.
Sure.
Yes. So I think we can go to. Okay, we need a final remark from you, sir, and Girish Nusnani, sir. Then we can close it.
Samir, these kind of cases, once you finish, you put them on IV GP blockers for about 6 hours, maybe 1 day.
So usually what I have started to do is, in recent practice, I have started to use Cangrelor. Although it's not a replacement, but I have found that the risk of bleeding actually reduces to a great extent, and the effect is very fast within 2 minutes. And in last 4 or 5 of my cases, just doing 1 pass of thrombosuction in heavily thrombotic lesions using Cangrelor for bolus and 2 hours has actually reduced my need for GP2B3 inhibitors. I try to minimize the use of GP2B3 inhibitors, especially in such patients who are ladies, obese. And if we are doing from the femoral approach, radial approach, fine. So we are now mainly doing our cases from the radial approach. But yes, if there is a macroscopic thrombus burden, at times apiximab or eptifibatide, my usage of thyroxine has been very, very less. And overall, with ticagrelor and prasugrel, probably the usage otherwise has also come down, sir.
The other issue is diameter of the stent, which is coming back to left main. You used a 3.5. I don't know which brand you used. Anyway, it's a material. But you would post-dilate the left main portion, the LED portion with 3.5 NC. And the portion in the left main would be stretched with what diameter balloon? 4 or 4.5?
So in the second case, it was a 4 millimeter balloon. And in the first case, it was a 4.5 millimeter balloon. The second case was a lady with a relatively short, the COVID patient was relatively a shorter left main, a smaller left main. So it was a 4 millimeter used there. But the first case, it was larger, so it was a 4.5 NC.
Yes, I would also feel that 3.5 stent may not always be 4.5 and more. I would probably feel that I would take a Foro stent in this case, deploy at low pressure. Then the LED can be stretched with NC, which is 3.5, and the left main could be done with 4.5 or 5.0, depending on IVs. But I mean, 3.5 balloon, even if you stretch it with whatever, or 4.5, will not achieve a diameter of 4.5. I would probably take a stent whenever stenting LED.
Thank you, sir. Thank you, Samir, sir, for a very insightful presentation, and Dr. Sama, sir. Thank you, sir. Sir, any final remark from Girish, sir, from your end?
Thanks again. I think they brought in 2 cases. I think very varied scenarios, acute coronary syndromes. Dr. Akbar's, double whammy is really overwhelming, and I should congratulate you. That patient is alive today. And same with Dr. Samir. He brought in a case of near impossible wiring situation, and he got away stenting and preserving the vessel. And Doctors Hiram sir's case was like amazing. It's blown the mind away, and a lot of insights into how do you implant so many stents, how do you strategize, and how to keep a tab on contrast, how to keep a tab on confusion of the wires. I think it would take people to even fathom the fact that it was done and how to do it, but it's just that what the youngsters can understand is it is doable. But don't jump into it, but it's doable. Spend and understand. So to me also, it was a great learning, sir. And it's a great evening. Thank you, MCure and Mr. Kesar.
Yeah, thank you, sir. Thank you so much. Once again, from behalf of MCure, I want to say thank yous to our both speakers, Dr. Samir Kuba, sir, and Dr. Sama Akbar, and our moderator, Dr. Girish Nasundani, sir. And also, Shri, sir, thank you so much, sir, for a wonderful evening and wonderful learning specifically for today's all the sessions, sir, and your presentation also, sir. Thank you, sir.
Really appreciate MCure's effort to bring so many interventions together. This is just a standalone set in by MCure, conducted by MCure, and carried forward by MCure. Hats off to such a huge effort on your part into an area which is basically interventional area. So thrombus is close to your heart, and intervention also is getting close to your heart.
Yes.
Maybe you should start manufacturing things.
Sure, sir. Thank you, sir. Thank you so much, sir. Thank you.
Bye, everybody.
Bye, sir.
Thanks
Good night,
for
sir.
joining us.
Nice. Have a wonderful vacation.